Welcome everyone to the May 14 COVID-19 clinical care rounds focused on emergency department, patient care, and clinical operations. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 emergency department challenges and successes in patient care and operations. If I'm an emergency physician preparing to care for many COVID-19 patients, the clinicians I want to learn from are those clinicians who have the most experience. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations who have collaborated, and we welcome Mount Sinai as a new collaborating organization. These rounds are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges in patient care with other clinicians. They are in many ways similar to what military medicine did in Iraq and Afghanistan to identify what works and what does not work, refining it over time and embracing a culture of continuous improvement that resulted in the lowest case fatality rate for U.S. service personnel recorded in the history of war. Our thanks to Project ECHO, Dr. Bruce Strumminger and his team for the peer-to-peer learning platform we're using for these rounds. The following information is important to share. We have upcoming COVID-19 clinical rounds. They are all currently US noon Eastern time. Mondays are EMS, Tuesdays, critical care, Thursdays, emergency department. Next Friday, May 22nd, noon Eastern time, we will be convening a COVID-19 clinical rounds special session on pediatrics and anticipate we will be having domestic and international participants. When we send out announcements for upcoming rounds, at times you'll not see speakers. They will be to be determined since we work to identify speakers and topics just in time, given the rapid changes and continuing rapid changes in our experience with the pandemic. As the pandemic has evolved, we recognize the need to have general sessions and then also do deep dives on emerging issues, much like we are doing with the pediatrics one for next Friday. For these rounds, we continue to have participants from all states and multiple countries, predominantly physicians, nurses, and EMS clinicians. Our appreciation is extended to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. These ECHO clinical rounds and NETEC's webinars are complementary to each other. Our appreciation is extended to the American College of Emergency Physicians and the Emergency Nurses Association in their support of these rounds. We received many questions for each of these rounds. We started with our first rounds with questions in the number of like 580 or so. They have diminished in numbers, yet the questions are just as important now as they were then. Sadly, we're not able to answer all of them because they just keep coming in volumes. We can't answer them all, but we do select major themes from questions we receive and hope to cover some of those. We'll also be doing polling questions, and we show results in real time so all of us have the opportunity to learn together. With that, I'm going to turn this over to Dr. Bruce Strumminger for logistics.
Great, thank you, Rick, and thanks to all the participants who are joining us today, and to the presenters and the panelists. Hopefully you can see my screen with the logistics. Great, so a few logistical items. There's a Q&A function in the Zoom bar at the bottom. If you can please put your questions and comments regarding the presentations there. And reserve the chat function also in the bottom toolbar of Zoom for questions regarding technical or logistical issues. And we'll be asking you a question, a crowdsourcing question, and we'd love your responses to go in the chat for that. This session is being recorded and your attendance is consent to be recorded, so thank you for that. The presentations are linked to the most recent email reminder from Project Echo. The slides and a link to the video recording will be on the Project Echo website. We'll be sharing that in the chat. They will also be shared on subsequent clinical rounds announcements that come out from Project Echo. There will be CME and continuing professional development credits available through the University of New Mexico. We'll be sharing a link in the chat at the end of the session. And there is a link in the most recent email announcement. You just need to complete a brief survey questionnaire, and that helps give us feedback to keep improving these rounds and guide us in the topics you want to see covered. So we really appreciate you taking advantage of the CME and giving us your feedback. So with that, I'd love to share the microphone with Sharon Van Ersdale with NETEC at Emory. Sharon?
Yeah. Thank you so much. Good afternoon. Good morning, everybody. My name is Sharon Van Ersdale. I'm the program director for Emory Serious Communicable Diseases Unit. By background, I'm an emergency department nurse. I'm always happy to be here on Thursdays. I'm also the director of education for the National Emerging Special Pathogen Training and Education Center. And it's just been such a pleasure and an honor to be able to partner with ECHO on doing these clinical rounds, which then allows us to do a deeper dive into the NETEC webinars. So yesterday, appreciate the Q&A, the comments that we're seeing. I'm glad folks enjoyed the PPE. You've got questions, we've got answers. That was recorded and will be posted to our website shortly. We do have a couple of upcoming webinars as well, one on rapid ambulatory COVID testing, so those drive-through kind of testing locations that you're seeing. We also have one coming up next week on incident command structures. And then we have two in the works, one on ventilation support and one on renal replacement support. So please check out netec.org for those upcoming webinars.
Great, thank you, Sharon. And we also want to highlight the AAMC has a wonderful clinical guidance repository where they've been curating resources from many excellent sources. And so we're sharing the URL here to that clinical guidance repository. So please go to the AAMC website and take advantage of that. And Rick, sharing the mic back with you for the crowdsourcing question.
Yeah, thank you. The crowdsourcing questions have yielded a lot of fascinating, insightful information and responses since we've begun doing these. And today, today's question really encourage you to respond to it. We've all learned from hearing from each other. So in that spirit, the question is, what has been the most positive unintended consequence of this pandemic in your workplace? What has been the most positive unintended consequence of this pandemic in your workplace? And I'm hoping there are some. It would be good to have some good ones. Let's see. With that, let me introduce today a little bit more in depth than I usually do. In the past rounds, because our intent was really to get to what I would characterize as in our healthcare system, we really wanted to hear from those that were seeing just huge volumes of patients to gain from their experience. And as the pandemic has evolved, clearly there have been many other institutions rather than the large institutions. For example, we had New York City and London in our last, the last rounds we did. There are many institutions across our country that have been considerably impacted by COVID-19 that aren't large institutions. And as we have seen in the questions and in the chat room, many questions have popped up throughout these rounds around rural areas and less densely populated areas. So with that in mind, we really worked hard to try to find locations that aren't necessarily like the biggest metropolitan areas in the country or the world. And with that, I'm going to introduce our first speaker, Dr. Harry Seibold. emergency physician and EMS medical director. He's the immediate past president of the Montana chapter of the American College of Emergency Physicians, immediate past state EMS medical director for Montana, and past president of the Air Medical Physicians Association. So with that, welcome, Dr. Seibel.
Thanks for that great introduction, Rick, and give me just a moment to see if I can repeat what we did and get my slides up here. And hopefully, if everything's right, you should be seeing my slides. I need.
Looking great.
Oh, fantastic.
Thanks.
Great. So this is me. As Rick said, I'm until just recently, for the last decade, I've been the state EMS medical director for Montana. So my travels have taken me from our largest cities, which pale in comparison to the New York metro area or Seattle or many of the cities in California, down to cities that are a speck on the map that you've never heard of. And let me see if I can advance slides here. There we go. So sadly, I have no financial disclosures. And what I'd like to talk about a little bit today is a rural perspective in our COVID response and some of the challenges that to some extent are similar to what others are experiencing, but sometimes are quite different. Just to let you know, those logos that you see represent my background for those of you who know me, and a lot of my working relationships, but don't necessarily indicate any working involvement from those agencies or specific concurrence with anything that I'm going to say. So what do you think of as rural? So here in Montana, we have roughly 150,000 square miles, a population of right at 1 million, and 10 counties on any specific day that have no resident physicians in them. So you can see that that's quite a challenge, and that's my definition of rural when you have more congressmen than you do senators. We have one congressman because of our population. You will hear me during this presentation speak specifically about Montana, though I think a lot of the concepts and challenges are going to be very similar to those that are faced by our rural colleagues all across the country, especially across the middle portion of our country and in the Rocky Mountain West. But almost every state has areas that face these same kinds of rural challenges. And so here's some of the good news. We have very few cases, a very low prevalence of cases in my state and in much of the Rocky Mountain West and Middle America. We have that low numbers of death and natural spacing. Our population density is very low, so we're very used to social distancing as a day-to-day thing. And I'll show you a little bit about what I mean by that. So we've all seen variations of this map. Now this is one that's showing real numbers and not any types of ratios. So those yellow states that you see, Montana, Wyoming, and then Alaska, that seems to have migrated magically down south of California, which may explain the receding glaciers, are the states that have the lowest numbers of COVID cases. Montana is number 2 in that. If you'll look over to the other side, you'll see Vermont, New Hampshire that trail far out in 4th and 5th position with twice as many as the other 3 states that I've mentioned right there. And here specifically is Montana. Total cases as of this morning, 459, total deaths 16, and cases in the last 7 days 2. And that's information that's current as of this morning. And actually, I'll go back and show you one thing. If you'll actually look at Montana and imagine where the capital is, I'm actually closer to Seattle than I am to the eastern border of Montana, though in spite of that, we still have this very low prevalence all across the state of Montana. And this is just to put it in perspective. You saw that 16 deaths. You see New York with 27,000 plus, New Jersey's nearing 10,000, Massachusetts 5,000, and on we go. So we're quite lucky in our low prevalence and low numbers of cases. There's some bad news involved in this too. in our rural populations, not just in Montana, but across the country, we have at-risk populations that are significant. Our rural towns are aging. There's been exodus, the younger folks from our rural areas. In Montana, we have 8 tribal nations. We know tribal nations have problems with funding of healthcare, access to healthcare, some genetic predisposition to illness. So that's part of our at-risk population in states like Montana and the Dakotas, Oklahoma, and many of the states. Our providers are at risk. The folks that practice medicine in our rural areas are aging, and that includes our EMS providers who are predominantly volunteers all across the country, not just in Montana. Specifically here, of our 5,000 plus EMS providers in the state of Montana, 70% of them all the way across the state, including our biggest cities, 70% are volunteers. And we know our volunteer population is aging. And there's significance to that in that some choose not to participate given their fear and their risk of illness. And that's certainly a reasonable response to this. As I said, there's some counties that have no resident physicians in them. And like all rural areas, we lack medical infrastructure in some places. The reason the bad news, summer is coming, everyone else seems to be thinking summer's coming. The natural history of viral diseases and pandemics is they tend to flatten during the summer. Well, in states that have rural areas, this is where people go to boat, they canoe, they kayak, they go bass fishing, they fly fish on our streams, they climb and hike in our mountains. And in our state, we happen to have these places called Glacier and Yellowstone, and just south of us, the Tetons, where everyone from the 4 corners of the globe descend every summer to see those areas, and from all across the country. In the Rocky Mountains, we plan our year-round wildland fire because we get hundreds, if not thousands, of firefighters that come in a bad fire year. And unfortunately, this is not going to be like last year where we had a great year that it was almost non-existent. 3 years ago, we had 1.8 million acres of fires in the state of Montana, and that's similar to all of the rural states around us. We had similar fire year, which means we have firefighters from all over the country arriving who may be shedding virus. The eastern half of Montana is the Bakken oil fields with transient populations, and when the weather breaks, ranchers and farmers harvest, and there's transient population to help them with that. And as I said, our low numbers of cases is a good thing. The modeling has been, previous to this, the modeling coming out of places like University of Washington and Hopkins has been very favorable for our summer. And that's based on the low numbers of cases that we have. I'll show you a slide here in just a moment. One of the things I've been worried about for the last couple of months and have voiced is that we have almost no exposure. There's no herd immunity. People, as we get further and further into this, everyone recognizes there's a certain amount of fatigue to our awareness and our preparedness, and we just get tired, and we start to say, how long can we do this when we're seeing no cases? Well, as of last night, I was in Montana Medical Association meeting, and infectious disease specialist out of Missoula dropped this slide up on the board, which was shocking to me. This is unfortunately one of the things I've been predicting. You see over here, we're in the second week of May, and you see the first week of May, our hospitalizations were almost zero. And if you make some different assumptions in the mathematical modeling, and all mathematical models are based on some assumptions, but if you say not rolling off all of the stay in place restrictions, but just some of them, you get to that middle portion. And if we just get to a looser phase 2 set of restrictions, again, not a free-for-all where everybody moves without any restrictions or advisories, you see this incredible peak predicted for the middle of July. So this was a rather shocking slide, but this was done by Dr. Christensen and the University of Montana team. And this also was pretty worrisome to me. As of now, as I said, our hospitalizations are extremely low and our population has very few cases. However, this is the prediction come middle of July and September. And if you look at what our total population is and the percent infected by this prediction and this modeling, that's pretty shocking to me. And I'm hoping upon hope that that's not the way that our model will be wrong, but this is one of the things that that may affect us. So let's talk some about specific challenges in rural areas and perhaps some of the solutions that that we can offer to that. Those of you who've never been into these incredibly rural areas where perhaps the town population is 76. There's one town in Montana that's like that. I've been there a number of times. We have rural hospitals. They're typically critical access hospitals that are very, very small institutions. The emergency department as such may be 1, 2, 3 beds and a room that's perhaps the size of your living room with curtains in between. And there's a door off the back, and you go through that door and you look down a hall and it kind of looks like a little bitty motel back there. Well, those are actually the hospital rooms. There's no negative pressure rooms in the majority of those hospitals. And in the some areas you get really sophisticated and you have a high rise, meaning there's a second floor, and that second floor is the nursing home. And the nursing home actually supports those critical access hospitals to a large extent. And it's very important for maintaining any medical infrastructure in an entire area or a county is keeping that critical access hospital open. So if you put the nursing home at risk, then you put the actual access to medical care in the whole area at risk. So a scenario might be you get the call in your receiving facility from in a regional receiving facility, and you listen to the doctor and you go, well, all this person really needs is some oxygen and some monitoring, and why are you calling me? Well, remember how I've described this hospital. They have no negative pressure rooms, very little ability to isolate a COVID positive patient. And if you get one positive case, then you perhaps shut down all of the medical access for that entire area. So just keep that rural challenge in mind if you start getting those phone calls as we start ramping up and we start getting cases when your cases are going down in our major areas. So those hospitals also have reduced medical capabilities compared to what many of us are used to. If there were an MRI available, it's in a trailer and is there on every other Tuesday. The CT scanner may not be a helical scanner and may not have the up-to-date software. And if you want to do lab tests after hours, you're calling a lab tech in from home. I had a conversation last night with a colleague of mine from a beautiful little area called Grangeville, Idaho, which isn't particularly small, but it's very remote and rural. And their hospital does have a co-location of all the medical office area for that city, or that town, I should say. But to get COVID testing of any sort, you would collect the swab, you would send it to Seattle, and their turnaround time right now is between 10 and 12 days. So there's no local testing available, and to get that, it's pretty limited. So that tells you some of the challenge that we have. Actually, I'll go back one slide and say one other thing. I do have some friends in another area. Since they've got some funding, I won't talk about specifically where this is, but their little local high school of about 500 kids had a very advanced science department, and one of the kids said, I think we can do this COVID testing, and I think we can figure this out. And once they demonstrated that they could actually do that, from that state, they got $1.5 million of funding to actually increase that, and the entire testing for that county is done out of the local high school. So it turned out to be a great solution to a rural challenge. Transfer capabilities, I've talked to you some about our volunteers in EMS. Remember, in those areas, usually you have one ambulance for the entire county. The staffing sometimes is iffy depending on who is able to carry the pager, or if there's no one available to carry the pager. If you have a positive patient and have an extended length of time that you're now trying to sanitize the ambulance, they're out of service for the entire county. So recognize that transferring is often a challenge in the rural areas, and that's some of the times why we request either your critical care unit or an air unit, simply because it leaves a rural area with absolutely no EMS coverage when they leave. It's probably pretty obvious to most of you after you've heard this description that most of our rural areas and all across America have a significant lack of surge capacity. And when we say that, we mean something different than if you're in Charlotte or New York or Washington, D.C. or Seattle. Yes, I understand your surge capacity limitations and difficulties, but when the definition of a disaster meaning something that overwhelms your local resources, we are one rollover MVA away from a disaster any day of the week. So if suddenly your county has a cluster of COVID positive patients and 50% of them are significantly ill, you have far outstripped the day-to-day capacity to take care of patients. And I'll give you a couple of quick examples of that. So as of yesterday, Oregon, 94% of the cases and 94% of the deaths and 84% of the cases were limited to 6 counties in Oregon, and the other 30 counties had a smattering of all of the other cases, which doesn't sound bad. However, let's shift one and a half states over across the panhandle of Idaho and into Montana. So we have one county that is 35th in population of less than 5,000 people. They have the largest number of deaths and the 5th largest number of cases throughout this COVID pandemic. And that started with one single case out of the nursing home from the critical access hospital. And they're now, like I said, the 5th most cases in the state of Montana. So that's how quickly things can go bad in a rural area like that. Everybody knows that we've seen this across the country, the reluctance to seek care. The difference in the rural area is it may be in counties that have absolutely no cases, have had no cases, and it's completely safe, but we're seeing the same challenge that you're seeing in the largest cities, and that is people that are reluctant to seek care and don't come in till they are significantly ill. I had a conversation last week with one of my colleagues in a small hospital, and she said, usually every 2 or 3 weeks we might get a code or someone that's critically ill when they hit the door. Now, recently, every single day I work a shift, I have a code. That is a significant difference in rural areas and is a real challenge to folks that are not used to that kind of volume of critically ill patients. So we're seeing the same reluctance to seek care. There's a slightly different impact in our rural areas. As I've said, we have workforce limitations and risks to those aging in the workforce. A lot of our workforce in many rural counties across the country are people that are working either part-time or they're locums, and they haven't had the time to develop those relationships within the referral pattern and receiving hospitals, which just makes that whole difficulty of transferring ill patients just a little bit harder. And we've noticed that PPE is available even in our rural areas, but it's scarce. And very early on, what happened here, and I believe that this is mirrored given that I've just come off a month DMAT deployment to Missouri, I've seen the same thing in rural counties there, very early, people said, we've got PPE, but we need to conserve that now. So very early on, extended use capability and re-sterilization and reuse of PPE was being done, because we're low on the supply chain, quite frankly, and not sure once our very limited supplies are gone, whether we'll be able to get them, realizing that we're using up this PPE without actually seeing any COVID patients, but we're doing the safe thing, worrying that our spike is yet to come. The other challenge is, when we talk about N95s, most of these counties don't have anyone that's available to fit test. So finding someone that can come and fit test is a challenge. That was one of the things that our mission morphed into with my DMAT team. We had 2 testers who, that's all they did day in and day out, was travel to rural Missouri and fit tested people in these institutions. As I said, we're a low priority for resource allocation that includes physicians, PAs, nurses, PPE, all of the resources that you might have. We tend to be lower on the totem pole simply because our low numbers, but that doesn't mean that the immediacy of the challenge is any less. And a question came up actually in a Montana Medical Association meeting last night. I'm trying to bring you the most up-to-date information. When and how are we going to roll out of universally donning PPE to see every patient? There were physicians on our virtual meeting last night that had no patients since the start of this, not a single patient, yet they were universally donning. And the concern was that they felt like, and we're getting feedback that from patients, that they seem to be sending the message that it's not safe to come to the hospital. And how do we roll out of that, and when does that happen is a significant question in rural America. So I just want to share one very interesting story about a challenge and a solution. PPE has been a challenge across the country. In rural states, people come to do things like fish and hunt and backpack. Well, those of you who are fly fishermen know Sims, and it is a fly fishing equipment manufacturer that's located outside of Bozeman, Montana. And they have ramped up their ability to provide barrier gowns with fabric that they have, and they've been approved to meet a specific identified technical specification by 2 of the hospital systems, and they are providing them at some cost to those hospital systems here in Montana. And it's just another example of American ingenuity and people's willingness to jump in and a specific answer in a rural state for a pressing problem. So with that, I'll stop for now and ask if you have any questions. Say thank you specifically to Project ECHO and HHS and ASPR, but especially to Dr. Hunt, not only for his leadership in monitoring this and all of our presentations, but specifically for inviting me to share my perspective. I'm quite humbled and very thankful to be able to present some thoughts to you today and hopefully stimulate some interesting conversation.
Harry, thanks so much for your presentation. You covered a ton of ground, a lot of rural ground in your presentation that many of the topics have been brought up in either the chats or in questions from participants around rural issues. And while, yeah, you don't, we all don't have solutions to many of those challenges, you at least got us thinking about, okay, some of what's possible and some of that ingenuity that can help. So I really appreciate your presentation. I want to turn this over now to our next presenter, Dr. Paul Mastro-Kyriakos, Medical Director for the Emergency Department and Chair of the Quality Improvement and Outcomes at the Southern Ocean Medical Center in Manahawkin, New Jersey, part of the Hackensack Meridian Health System. So Paul, with that, while you're working on pulling up your slides, I do want to recognize the great responses to the crowdsourced question. When I say great, well, I mean the character of there's a lot of diversity in terms of like what those responses were. They're extremely varied. There's at least ones I've been able to see a lot of about how we've got the team building thing going on, the support for healthcare workers, but it's been really gratifying to see the responses. So if you haven't participated in that, please do respond. With that, I'm going to turn this over to Paul. Paul, thank you very much for joining us.
Thank you for inviting me. Can you see my screen?
Yeah, it looks great.
Okay, good, because what happened earlier. So again, thank you for inviting me to participate. You know, Southern Ocean Medical Center, you know how compact and how densely populated New Jersey is, but we are about 20 miles in any direction from a hospital near us. And what's even more interesting is we're at the entrance to Long Beach Island, which many people from North Jersey, New York come to visit and have homes in. It's 17 miles of one house after the other. And our general population that we care for is about 100,000 people. However, during the summer, it swells to 350,000. I think we're getting close to 250 or 300,000 right now, as people are trying to find a place to go and try to get out of their homes from from staying at home. It's a 170-bed hospital, roughly, and we see about 42,000 visits per year. Our number one priority when we set out on this journey was to, take care of our patients and then also protect our patients and protect ourselves from infection. So we operationalized an awful lot of things, a lot of processes to try to accomplish that. So I thought I would keep most of my comments on what we did operationally to achieve our goal of taking care of our patients and protecting them, which is a big fear for them to come to the hospital. Knowing, especially when all the ads in the newspapers and on TV say, if you take care of yourself, you help take care of us. So that means, just be careful and don't come to the hospital, unfortunately. So we did everything we could within our small venue to accomplish that. So as far as how you achieve care in our emergency department, number one is through EMS, and all EMS calls us and tells us they're on their way in. Not necessarily with just COVID patients, but with any patients. So we just assume that everybody has COVID until we meet them and talk to them. The EMS squads come right to the ambulance entrance, and that's where they stop. They transfer the patient onto one of our stretchers and also are greeted by one of our nurses who determine the placement for the patient. Unfortunately, one of the problems with the EMS in our area is that there's no, at least I haven't seen any set PPE for the first responders. Most have N95 masks, most wear gloves. Some have those Tyvek suits that are total body. Some EMS responders have, either the mask or they have their own 3M respirators, and most all of them, if not all of them, are wearing goggles. So everyone is transferred to one of our stretchers, interviewed and evaluated by one of our nurses who's in full PPE, and then transported into our department so that there is no exposure of EMS equipment or EMS personnel to our emergency department, short of dropping off the patient. That also helps them save their PPE, because once they get exposed or once they move into our areas, they may be exposed, and then also their equipment may be exposed, and it gives them the opportunity to save their PPE. Our walk-in patients, as soon as they walk in, we did not have a tent, and although a lot of emergency departments on the East Coast, especially a state so densely populated as New Jersey, had tents outside to greet patients, we did not have a tent. So what we did was we created a 2-pathway system, and The patients were greeted in our emergency department waiting area quickly. We're given a mask, we're given hand sanitizer by a dedicated tech who's out there, and quickly and saw a quick, had a quick triage with a pivot nurse. We developed an area that was where the worried well, those patients who had a cough and were concerned that they had COVID. They had a fever yesterday, but maybe not today, and they wanted to know if they were exposed or if they're infected. So we created an area directly right off of our one triage area, and those patients went there where a provider would see them. They may get an X-ray, they may get a lab, but they're generally patients that we felt were going to get discharged. In the initial stages, and even till today, patients that we see that are discharged from our hospital are generally not treated, are usually not tested in our emergency department. We provide outpatient testing for them. So what we did with our emergency department is we wanted to make sure that the patients who came in ambulatory felt that they were safe. So we have two triage rooms, and we call them one the clean room and one the COVID room. When they go through the system, when they go through our emergency department, the two paths never meet. So a patient who comes in with, let's say, an ankle injury will never see or be exposed to a COVID patient. And just to the corollary, if somebody comes in with nausea, vomiting, diarrhea, cough, fevers, chills, we'll never see or come near anybody who has an ankle sprain. So their ingress and egress from the emergency department are two different pathways, making it very, very as safe as possible for the patients, but also not to confuse the staff as to who's COVID, who's not. I know that there's 80% of the population that does not have that don't have any symptoms, but those that do have symptoms, at least we can protect the patients and ourselves. We have a two-pod emergency department, so we dedicated one pod as the COVID pod and the other pod as the non-COVID pod. And we also had a fast-tracking peds area that we used for overflow. We created a buddy system. So, and I'm going to strictly talk about the COVID area. The nurse and the tech would don completely protected face masks, N95s, gowns, gloves. The nurse would go in to interview and evaluate the patient. The tech would be just outside providing the support. Both didn't go in. That saved a lot of PPE for us. A couple of other things that we did, some similar to the buddy system. If someone needs to be intubated, you don't need a cast of 6 to intubate somebody. You need a provider to intubate the patient. You need a respiratory tech to bag and to secure the tube, and you need a nurse to push the drugs. So you really 3, and at sometimes even 2 can possibly accomplish this. So we minimize the number of the number of people that were exposed. The other thing we decided is we only did x-rays that were portable. Every x-ray in our department is done portable. And this is kind of one thing we also did was, most of the time we need chest x-rays, if anything else. At 8 feet through glass, you can do a portable chest x-ray. You don't need to, the techs would come in 2 by 2, and you'd have to fully don and doff every single time for them to do a portable chest x-ray. So what we did was we allowed and asked the nurses that were in the room already, fully gowned, to put the film behind the patient, to put the x-ray film, I guess not called film, forgot, it doesn't matter. But anyway, we would place it behind the patient, the x-ray tech, and only one of them would have to get done and doffed to take the x-ray. That saved our PPE. So those are just things that helped what we did. The non-COVID area, and oh, by the way, it's one doctor and it's dedicated staff of nurses and techs that are in that area the entire day, so as to limit the exposure. And then usually we would rotate out so that you would be in there 1 day a week. If there's 7 of, we have 9 doctors, so 1 every 9 days you'd be in that bubble. The non-COVID area is exactly the same, except that we may not wear gowns, but the masks, the N95s, the face shields, the gloves, all of that was happening. So the most important thing that we tried to accomplish in our emergency department layout for patients who came in is that the two paths never crossed. And that was so important. The buddy system was very important. The portable x-ray concept is also very important. It limits the patient's exposure throughout the hospital. Our successes, we only had one person that turned positive so far in 2 months. And that person has recovered and is already back to work. We successfully separated our patients, and I thought that was critical. And that alleviated a lot of the fears, and patients were very surprised that that they didn't come into contact with anybody they perceived was sick. We limited the exposure of our EMS squads so that they can be out doing the good work that they do throughout the community. We limited exposure to our patients and to ourselves, and in the process saved an enormous amount of PPE. Couple of really cool things that we did, and we did this early on. We found that we didn't take time to drink water. So every hour we have an announcement. Don't forget to drink your water and to clean your surfaces that you're working at, just as a protection. We started cleaning our masks and PPE, including our shoes and backpacks. We put them all in one room, and we would do the blue lights twice a day to eliminate any kind of infection on them, so we also didn't take anything home. We ramped up communication with other departments. So for example, if we knew that there's a patient that's a high risk and high reliability that they're COVID positive, we would call radiology and CAT scan and tell them that this patient is high risk. You need to make sure that you protect yourself, just adding another layer of information for them. And last but not least, the biggest success is everybody in our department had an idea to keep them involved, to keep them focused. We did everything we could to implement many of the ideas that staff, nursing, doctors, physicians, nurse practitioners, and our techs came up with. Our challenges, and I know that this was told by Dr. Seibel. I call it the human factor. It's called COVID fatigue around here. You get too comfortable. You start taking shortcuts. We've been very successful for 2 months not getting all but one infection in our department. And people start taking small liberties. And I even find myself once in a while leaving my documentation bubble, forgetting to have my mask on. Well, luckily we have a take no prisoners attitude around here. I probably will have 3 or 4 nurses and 3 techs yell at me within 10 feet of leaving my bubble without my protective gear on. And it's just it's an important thing to look out for each other. One of the other things, when will this end? It's fatigue. It's more of the same. You get tired of seeing the same types of patients: fevers, chills, cough, diarrhea. We look forward to taking care of patients, and when one comes in that's unfortunately having a stroke or an MI, because they're few and far between, and Dr. Seibel commented that a lot of patients are staying away. And now we're seeing the patients coming a week later with strokes, a week later with NSTEMIs, with elevated troponins, with anemia, GI bleeds, and that's happening now. Sadly, because we also have told patients that don't come to the emergency department, we've had to furlough nurses, we've had to furlough nurse practitioners, we've had to, we've seen 50% less patients, which is a problem with our salary and our workflows. One day, on Monday, I worked and I saw 19 patients, which is 10 patients more than I would normally see. 10 patients less than I would normally see in a shift, but 10 patients more than I was used to seeing. And I was kind of out of sorts after 8 weeks to see that many patients. You kind of lose your focus. It's kind of eye-opening. Operationally, donning and doffing is very difficult. We don't have any empty rooms. I don't know if you guys do. You have to be very careful how you put them on, how you put them off, how you take off the stuff, because you can infect yourself. The other thing is moving patients around the hospital if they're COVID positive is very dangerous and very difficult. So we're pretty much doing every test that we need to do, including Dopplers if the D-dimers are positive, CTAs, before any patient goes to the floor to minimize other staff and other areas of the hospital becoming contaminated. And of course, we always have the airway management and oxygenation issues. You know, we built our own plexiglass cube for intubations. We only use a glide scope. We only use nebs if we absolutely have to, and then we use the non-aerosolizing neb apparatus to give it. We don't use CPAP, we don't use BiPAP. And of course, all those, and we do have OptiFlow for high flow oxygen when necessary also. So all of these are challenges. And of course, these are all the same challenges. But I think the number one thing from the challenges here is that you have to look out for each other, don't get fatigued, listen to your coworkers with any great ideas, and try to implement them as much as possible to keep everybody still focused. And having said that, if you have any questions, feel free to ask. We'd be happy to answer.
Hey, Paul, thank you very much for your presentation. For me, so I had some take homes that I haven't heard in the rounds we've done to date, the every hour water cleaning announcement. That's cool. It probably did a lot to hydrate people. The idea is.
It gives you a minute, by the way. That one, I'm sorry, my ADD is acting up. It gives you a minute to take the mask off and to stop your CO2 retention from having it on for 2 hours and 3 hours at a time.
Well, it's a very cool thing. And by the way, Dr. Bittinger here on the Hollywood Squares, he uses these rounds to do his water break, as we've noticed over time. So at any rate, it's true. See, and then I think the fatigue factor that you mentioned, I think it's a pervasive feeling based on the discussions that we've heard on the rounds previously. And I really appreciate you reinforcing that, plus taking the ideas by your staff. Heard that one before, but reinforcing that's really important. Okay, so we've got like 8 minutes till the top of the hour. So we're gonna do like lightning polling rounds. So those of you who are doing email, get off your email because I'm gonna need really quick responses. And then we'll go like we have recently. I mean, we're all working through this together. We're going to go around the Hollywood Squares for responses, reactions to anything during the rounds, comments on anything that was said by the speakers, but also based on the polling responses. So if Echo could please start the polling. And we're going to, this is ED round, so that we're not going to spend a lot of time on each of these questions because we've got the next the next question to go to. So anyway, first one, I am an emergency physician. Hopefully that's a cue there, just ED docs. Since COVID-19, my number of hours working has decreased. My number of hours working has increased. Pay has decreased. Pay has decreased. Pay has increased, and none of the above. So go at it, and 10 seconds on it. The next one's going to be to cue this up. All the emergency nurses that are participating or on the panel, panelists can't vote, so that doesn't work. You're up next. All right, stop on this one. Okay. All right, thank you. Next, same question, only for emergency nurses. Mike Hastings, you can't vote, but I hope you got some of your fellow, and Sharon, you can't vote, but I hope you got some of your fellow emergency nurses on here. I'm an emergency nurse since COVID-19, and it's the same potential responses. Numbers of hours working has decreased, increased, pay has decreased or increased, and none of the above. 10 seconds. Okay, stop. Wow, I will tell you, the increase in number of hours, that to me, I'm surprised. Mike and Sharon, you might not be surprised, but that surprised me. Okay, next. Our ED is preparing for a second wave of COVID-19 patients. Yes or no? 10 seconds. All right, stop. Interesting. Next one. For emergency physicians and nurses, in the next 6 months, this is basically where you're going to end up working. I plan on working at the same place I am today. I plan on leaving emergency medicine. I plan on leaving emergency nursing. I plan on moving to a different emergency care workplace. Don't know how the gowns got in there. Not short of any PPE. Just disregard those as potential responses. Go. And stop. I'm actually, for me personally, I'm encouraged by people who are looking to stay in the same place. It's actually very encouraging to me. Next. Next question is, I know an emergency physician or nurse who has been unable to work one or more shifts due to mental health impact of the pandemic. Yes or no? Again, just 10-second question. Okay. I didn't know what to expect. I knew there would be some. 41% said yes. Next. This one you actually have to, you gotta think about this one a little bit. If there were no actual or anticipated shortage of ventilators, which ventilation support strategies would you use for critically ill COVID-19 patients? Select all that apply. Proning, early intubation, high flow nasal cannula, CPAP, BiPAP, helmet-based ventilation. So again, if there were no actual or anticipated shortage of ventilators, which ventilation support strategies would you use? Select all that apply. You have like 15 seconds for this one. Okay, let's stop. Looks like proning high flow nasal cannula being the winners there. Next one. I think we only have a couple more and then we'll go around the Hollywood squares here. Our ED has administered remdesivir to COVID-19 patients. Yes or no? So easy 10-second one. Okay. 14% said yes. Huh. All right, next. For all today's rounds participants, everyone in the room, do you trust COVID-19 testing results? Always, sometimes, never. Just pick one. Okay, stop. That's a curve. How about that? Next. for all today's rounds participants, doesn't matter what discipline you're in, what country you're from, state, for all the participants, I have cared for COVID-19 pediatric patients. Yes or no? 10-second one, easy. Okay. Wow. Yes, 25%. All right, next. Echo, is that it? Must be.
That's everything.
All right, thank you very much. All right, so we're going to go around Hollywood Squares and go with our panelists and speakers. You'll be last up for the last word. It's only right. Okay, so Dr. Schneider, any responses to either the speakers' presentations or the results?
Well, I thought both of the presentations were absolutely impressive. And I think it points out that this is going to be impacting the rural areas in a greater amount. And they are less capable of doing that. And also, not mentioned on this, but I think Harry alluded to it, are the tribal nations, particularly the Navajo Nation, I know is being hit very, very hard right now. So much so that Doctors Without Borders has responded within the United States, I think perhaps for the first time. I really thought the question about when can we end PPE is really important, and I absolutely don't know that, but we will be talking with the CDC later today. I'll pose that. I don't think they'll know either. I'm just not sure when it's important. I do want to mention, by the way, our field guide. I keep mentioning it every week, but if I can brag a little bit, we've reached over 110,000 page views. And it's been translated by volunteers, not ours, but just people in the country now into 5 languages. So I think that's amazing. And if I have one more thing I can say, this weekend Grubhub is putting on a concert to honor emergency physicians. There are 2 people from, I understand, millennial type things. I'm sorry, it's not the Grateful Dead. It's not anybody that I've ever heard of because I'm too old. But in this time, if anyone orders a meal, they will be giving away 10 free meals to ACEP members, and I encourage ACEP members to sign up for them. I understand we can then volley that to a friend or a resident or a nurse or someone or even an EMS person. So please sign up for that and join me in watching that Grubhub concert to honor us.
That's great. Thanks, Sandy. Those are important advertisements, seriously important ones. Thank you. Appreciate it. Sharon, I know you got to go, but if you, yeah. Before you go, anything?
Yeah, I mean, I think you mentioned it already, Rick, in how many folks think that they'll still be in this field in a year. And I was reassured to see that number because we already have challenges with turnover in an emergency department setting. So it's reassuring that folks haven't given up and want to keep fighting. So keep on keeping on.
Thank you. I just saw like Barbara pop up with a comment about the wording of the trust testing question. You know, I could use some help with some of the wording for some of these questions, but they're not bad. So I'm working on it. All right. So Anna.
I would just say I'm really impressed with what all the comments were about the good outcomes of COVID, one of which was communication. And I think that that's really, really important. That's something we've been working through at Emory, and it's been interesting and good to see kind of how communication has evolved, and hopefully we'll continue to communicate well.
Thanks, Anna. And thanks for joining us. Mike?
Hey, yeah, thanks, Rick. Yeah, I kind of echo, both presentations were great. It's reassuring, again, what Sharon has said about people wanting to stay within our profession. That's a big concern. Always, especially the mental health of our healthcare workers right now and facing it. So I'm proud that, ENA, the Emergency Nurse Association, we've partnered with some other organizations to offer some peer support groups now as well for our members that are free, for our members to be able to help them get through these times because we are in this together. I did post on a link as well the new resilience video, that's our sound video that came out, that was a partnership with ACEP and ENA and some over 60 Broadway actors and singers that did it. So it's a great video. If you haven't seen it, I honestly watch it multiple times a day because it's just great. So thanks to everybody for their great work on all this stuff. And we will get through this together. If we only had that crystal ball so we could know when we could stop using all that PPE and try to get back to some normal sense of life. That would be great for us all.
Hey, Mike, where's that? Is it on the ENA website, the video?
Yeah, it's on the YouTube. I put it in the chat feature. I can post it up again.
Well, I've been a little bit busy. I mean,
it's all good. I'll send it directly to you, Rick, as well.
No, it's fine. Thank you. Paul. Hey, Paul, thanks for joining us. Seriously. I know it was a cold call. Yeah, you got to go off mute. It's a lower left-hand button, not on most machines.
Yes. Well, thank you for inviting me to participate. I think it's important for all of us to find ways to keep our patients safe so that they feel safe to come to our emergency department for other conditions. And I'm not so sure we've done such a great job of telling that to the population. And the second thing is we need to be vigilant for ourselves to protect ourselves when we're having that fatigue factor. And I think we need to find cool and intuitive ways to keep the staff involved.
Yeah, and thanks for keeping your staff involved. That came through loud and clear. Harry.
Well, I wanted to say thanks to everyone for all of their engagement. I've been trying to bounce between the Q&A and the chat and answer questions live as quickly as I can. Dr. Hunt keeps a list of those, and I actually looked at the previous list, and we just don't have enough time. There's several of those I would love to respond to, and if we have a mechanism, I'd be glad to respond to people offline. Michelle Williams had a great question about PPE and how volunteers deal with getting new PPE and sterilizing used PPE. I'd love to respond to a number of these. And I'm humbled and honored to be amongst this group of people that is so dedicated to this mission. And it's a critical mission, and it continues to go on. And I really thank everyone that's here attending, and especially the Project Echo folks and Dr. Hunt for the invitation.
Thanks, Harry. Bruce?
Just thanks again to everyone, particularly Harry and Paul, for your wonderful presentations, and for Sandy and Anna and the other panelists for continuing to join, and for all the attendees. There were over 400 attendees today. So thanks, everyone. Please take advantage of the CME. We shared that. It's in the announcement. Give us your feedback and get your CME credit, and be well, and see you next week.
And thanks, Bruce, and thanks to the participants. I mean, the Q&A and response to the crowdsourced questions, a lot of great stuff there. This truly, it was always intended to be peer-to-peer learning, and it's actually gotten there for sure. It was there at the beginning, but it's gotten increasingly better and better in terms of learning from each other. So thank you for doing that. And to our panelists, Sandy, thanks for showing up every week from ASAP, the other panelists as well. Thank you. And Paul and Harry, there's a lot of people from big institutions have been on this platform. You're big institutions in your own right, and deeply appreciate your sharing. So thank you all, and be safe, take some time off, seriously, and be well. Bye.